Hey folks, Scott Weingart here, and this is an EMCrit podcast. This is another cardiovascular EMCrit podcast, which means I have my buddy, Trina Augustine. And today, we are going to do part 2 of inotropes. In part 1, a couple of weeks ago, we discussed the 3 big inotropes mainly. We had dobutamine, which is the chronoinotrope. We had milrinone, which is the inodilator. And then we had epinephrine, which is the pure inotrope. We discussed doses, the ranges, the side effects, etc. of all those agents. This time around, we're going to be discussing specific scenarios and what we choose in terms of inotropes for those scenarios. Now, this might also generate some controversy, and if it does, please put it in the comments section of this episode, emcrit.org/394. Before we jump in, let's hear about a conference that I really think you should think about joining us for, and then we'll get into the show. All right, here's what I want you to know. Reanimate 11 tickets are now for sale. Reanimate is our resuscitative ECMO conference with VA ECMO, eCPR, Crash VV ECMO. It is in San Diego every year. It is November 12th and 13th, and it sells out rapidly every single year. Every single year, I keep doing these ads. People are like, I'll wait. And then they decide to buy their ticket 2 months beforehand, and we have none. And they're like, oh no, I wish I really wanted to come this year. I'm like, yeah, then you should have done it when I talked to you in January. So if you want to come to Reanimate, now is the time to buy your tickets. Go to reanimateconference.com. That's reanimateconference.com. Buy your ticket, and then you will not miss it again this year. All right, let's get to the show. All right. So let's start with septic shock, and the patient has some degree of myocardial dysfunction on their echo. So sepsis-induced cardiomyopathy. Now, a lot of the papers I've read, Trina, say that you could give all the inotropes you want, but all you're going to get out of them is tachycardia in a septic patient, and the contractility doesn't come along with it due to the unique milieu of sepsis cardiomyopathy. What has been your experience, and what do you grab in these patients?
Yeah, so I love this. I think for me, it's a little bit variable. I do find that these patients sometimes will need an inotrope, and in fact, sometimes will need ECMO. I think that you can do it a couple ways. So one, typically these patients, you're on norepinephrine already. So oftentimes I find that these are the patients that low dose dobutamine, like 2.5 to max 5 micrograms per kg per minute, can get you to a nice spot. And it might be just enough increase in cardiac index or cardiac output. What I'll tell you is you don't often need a normal numbers. Everyone tries to make all the red check boxes, black. You don't need normal numbers. You just need to give them enough to allow for end organ perfusion and normalization of your lactate, kidney function unless they have ATN and you can't follow that, all of those things. The other thing that I'll do is low-dose epi. And, they might be on norepi, and I'll just add a little bit of low-dose epi. Those patients that are already on high doses of norepinephrine, I might put them on epi, maybe 0.02 to 0.05 micrograms per kg per minute. And that can give you just enough to give them that nice kind of increase in contractility and cardiac output to get you through. I think on that subset that is so sick that you are having to go up and up on your stuff, if you're hitting epi 0.1 micrograms per kg per minute, I cap it there. I don't go higher than that because I don't think you're going to get an increase in inotrope. And, these are patients that are already so vasodilated out that milrinone and dobutamine are tough. If you get to that sick of a subset of patient, then I'm guessing you're also starting to think about, do I need, advanced support? Do I need mechanical circulatory support like ECMO? And we've shown actually in these patients in this population that those, especially, EF less than 30, but especially EF that's kind of single digit or less than 20%, some of those patients can do really well because this is really a reversible cardiomyopathy.
Yeah, absolutely. And I think Europe has been leading the way on ECMO for sepsis, and it just hasn't hit as hard in the US, unfortunately. And I think that'll change as more evidence comes out. All right. You're doing very much what I'm doing. I'm usually just grabbing epi because, again, I'm trying to teach the residents, just like I only want them doing one technique at intubation. I really just want to give them a package of, here's the vasopressors you need to know. Here's the one inotrope you need to know in emergency medicine. Work with it. So either dobutamine or epi makes a lot of sense. I'm usually grabbing epi. When would you actually say from the ED? Have you seen a patient in the ED that needs referral for mechanical circulatory support consult that early on, or is this a developing thing that you'd only see in the ICU?
With a septic cardiomyopathy, I actually haven't typically seen those in the ED, and I've cannulated these, but they're almost always in the ICU setting. And it's not that it's not possible. I mean, you could have that patient that presents with kind of full-blown sepsis that's been at home for a while and comes in extremis. It's possible. But I will tell you the most common times this consult comes is from our medical ICU, where they're patients who've been sick for, 48 hours at least, and they suddenly have this massive inflammatory response. They've had, a significant hit to their myocardial contractility. So typically not there. Now, it's not to say that you should just say, oh, I'm in the ED, then I'm safe. It's possible, but typically this takes a little bit of time to develop.
That's been my experience as well. And I can't remember a patient, an ED, that I had to refer to MCS. It does, just to my mind, just bring up another agent we should discuss before we go any further, and that's calcium. Yeah, calcium is an inotrope. In fact, I remember just so well one patient. She was like a 75-year-old woman, and we were just maxing out on all our vasopressors. We were adding in a ton of inotropes, and we finally got the iCal back, and it was quite low. And calcium reversed everything. Like, she went down from like 30 of norepi to 2 of norepi. And I know some of the anesthesiologists will actually run calcium as a drip, particularly for inotropy. What's been your experience with this?
Yeah, so I'm laughing because we call it God's inotrope. And the reason is if I have a patient that is completely extremis, dying in front of me, that I need to get to the operating room, I'll tell you that standing there pushing sticks of calcium, you'll get them there. Now, is that all good? Probably not. But I kind of joke it can make anything squeeze. So clearly it's going to help your pressors be more effective. And it's also, has inotropic properties on its own as well. So I do use it. Do I use a calcium drip? Occasionally. I'm going to be honest, those are patients that are in extremis, and typically it's started in the operating room and comes up to me, and I try to get it off as quick as I can. But I will tell you, I pay very close attention to ionized calcium on patients in cardiogenic shock. And if it is low, I replete it. There's not good data on it, but you and I both know, you watch vasopressor requirements go down by half. I mean, it's hugely, hugely different. So I do think that this is maybe a practice pattern change for some people who aren't as used to really looking at that ionized calcium, especially from the emergency department. But yes, if you have hypocalcemia, replace your calcium and you will see significant improvement in their blood pressure.
Yeah, that's been my experience as well. If their calcium is good, and we're talking ionized calcium, not just the calcium you get on a regular chemistry, that's going to send you astray in a critically ill patient. But if your iCal is good, I haven't seen as much response in physiologic doses of calcium. Just as you say, if you push it hard, you'll buy 20 minutes. It's kind of like the hyperventilation for getting the patient up to the OR with intractable herniation. But it's not, I think, a good long-term strategy to push these patients to crazy levels of calcium. All right, let's talk about your bread and butter cardiogenic shock. And let's first talk about the patient, cardiogenic shock with preserved blood pressure. And so what is the agent you reach for in those patients?
Yeah. So when I have a patient with preserved blood pressure, they come in, it's the typical low cardiac index, high systemic vascular resistance. That's when I love milrinone. In my heart of hearts, even though we don't have a study that says one inotrope is better than the other, it makes sense that an inodilator would be better. And, we have non-randomized trials that point towards that, definitely. But if you think about it, a drug that's going to decrease afterload and not cause as much of a heart rate increase and going to increase their contractility does sound like a much better agent. So I do love low-dose milrinone for those patients. And, especially if they have good renal function, that is my go-to of choice.
All right. Makes sense. Now, a lot of times I think in the ED and even the cardiologist, this is what they'll ask for. They'll ask for low-dose dobutamine. What is their rationale? Is it that they're worried about the titratability and issues we've mentioned with milrinone? Why are they over the phone saying dobutamine?
Yeah, so I think partially. And, I will tell you that part of this is practice pattern, where you work and how you were trained. So our CICU loves dobutamine. They use a lot of milrinone too, but they love dobutamine. And in fact, that patient that I sent up to them on low-dose epi that was doing well, they put them on dobutamine, and then suddenly they went into, a significant chronotropic response, and it was problematic. So some patients it works, some people it doesn't. What I will say is that low-dose dobutamine in a scenario like that is not the wrong choice at all. In fact, it's a great choice. But I would kind of emphasize low-dose dobutamine, 2.5 to 5. Don't get heroic and go to huge doses on it. It's recommended, I think, a lot because it's quick onset. It's easy to get anywhere. It's, maybe a little safer in hands that aren't as used to working with inotropes, because even if they went big, you can kind of turn it off, and at least hopefully soon you can have the situation salvaged. So I think it's a great option. And that's what I would probably recommend on patients that come in the ED. who are, hemodynamically stable, but are cold and clearly underperfused with end organ dysfunction.
All right. What about the patient with decompensated cardiogenic shock? They're hypotensive, they're crashing. You've put them on the norepi, which I think should be everyone's first grab for this to temporize their blood pressure, get their coronary perfusion going. And now you want to add on an inotrope. What are you grabbing in these patients?
100% low dose epinephrine, 100%. And I'll tend to start them anywhere from 0.03 to 0.05 micrograms per kg per minute, very rarely above that. And what I'll tell you, and this is just anecdotal, my own experience, I think almost never run epi.
Hey folks, we're just going to stop for a second because this is a free episode. I'm giving it to you in its entirety, but it's very rare that we have these full free episodes because EMCrit is a members-only site that still has foam. But if you're enjoying this content, please consider becoming an EMCrit team member. It's inexpensive. You get CME. You could write it off on your taxes, but forget all that. What it's going to do is make you the best possible resuscitation and critical care doctor you could be. You'll have the most cutting-edge, up-to-date information, and you'll get it in the comfort of your car or on the subway or while running, and you'll never have to think, am I current enough or not? Am I taking the best care of my critically ill patients? All right, let's get back to the show.
Of 0.08 micrograms per kg per minute. And what I've seen is that above a 0.06 micrograms per kg per minute, when I'm watching my index and SVRI, there becomes a little trade-off. I feel like my systemic vascular resistance starts kind of rising around that level. So it's different based on the patient in front of me, but, more is not always better. So this is a drug that when you're doing that, downstairs in the ED, if you started at about 0.03 to 0.05 micrograms per kg per minute, or kind of sitting in your range. I love how you talk about that 1 to 5 mics per minute. I think that's great to keep in people's heads. I just wouldn't go higher than that.
Yep, couldn't agree more. All right, let's talk about the complicated one. Patient with right heart failure or pulmonary embolism-induced right heart failure. They're crapping out. And now we need a complex mix of agents. So let's first discuss your vasopressor choices in that patient, and then we'll discuss inotropic choices as well.
Ugh, I love this. So I think this is one of the more nuanced patients and also can go wrong so quickly and so badly. So, the big thing that I always want the listeners to remember with RV failure is protecting coronary perfusion pressure and perfusing that RV is so important. So I love that you asked, let's start with the vasopressor, because absolutely, I start with the vasopressor first on these patients as well. The textbook answer and what I do like to use is vasopressin. But what I find is that, unless you're bolusing vasopressin, it's only so strong. So I think it's great to grab the vasopressin and put it in line, but you might need a little something else. Now, you can use norepinephrine, and that's fine. It's not wrong. It does have effects on the alpha receptors, and so you might increase your pulmonary vascular resistance a little bit. Frankly, I tend to like epi here, low-dose epi, because, you're going to have beta-2 effects as well as maybe a little alpha effects. But at low doses, I find it to be fairly neutral on the pulmonary vascular resistance. Textbooks might say it increases it, but I find that it's fairly neutral between the beta-2 effects and the alpha-1 effects at those low doses. And you also have that little bit of increased contractility. So for me, vasopressin and a little bit of low-dose epinephrine tends to be what I love. But you can do it with norepinephrine as well. Just stay far away from phenylephrine on this patient.
Yeah, I mean, what you elaborated is exactly what my feelings are as well. Vasopressin and epi, they're right up front, and then add in norepi if I need additional squeeze. You said something intriguing there. Are you bolusing vasopressin?
You know what? I do not typically do that, but you can if you're somewhere that stocks like the 20-unit vials, and you can mix that with 19 mLs of saline and kind of have that 1 unit to 1 ml concentration. Sure, you could bolus a unit, but I'm a huge advocate of push dose pressors. What I will say though is if you're not comfortable mixing it up and bolusing it, there is real risk for error, especially with a drug like vasopressin, where you're just not as familiar with it. So I don't necessarily recommend it being done in the emergency department setting. We do it in the critical care setting. So yes and no.
A lot of the textbooks will mention milrinone as a choice here. In the ED, I think that's a bad idea for all of the reasons we've mentioned, but it does have, at least theoretically better effects on the pulmonary vasculature than even agents like dobutamine and epi, which are probably neutral, but milrinone might actually be beneficial. When would you be doing something different in the ICU? Would milrinone have more predominance in your use?
Yeah, so you asked me what vasopressor I'd use first. So when it comes to an inotrope, I do love milrinone for RV failure. And part of that's because, you get this drug that's going to cause beautiful increase in contractility, lusitropy, so the increased relaxation, and it's going to cause a decrease in your pulmonary vascular resistance. Now, it also causes a significant decrease in your systemic vascular resistance. So just be aware of that. It can cause hypotension. And the reason I bring that up is I do love it in RV failure. But my pet peeve in RV failure is when people are like, oh, you're in RV failure, I'm throwing on milrinone. And I walk in the room and their MAP is like 55 and they're hypotensive and they're literally going in this like RV spiral of death. And I'm like, no, you need to protect your coronary perfusion pressure. So I do use milrinone in RV failure, and I use it frequently. It's often at low doses, 0.125 micrograms per kg per minute to 0.25 micrograms per kg per minute. That is only after I protected the MAP, and it's only if I am able to protect the MAP. If this is a patient that just vasodilates out and becomes hypotensive, it comes off, because then it will be more detrimental than good. But in my perfect world, I have low-dose milrinone on with a little bit of vaso and maybe low-dose epi, 0.02 to 0.03 micrograms per kg per minute. And that tends to get you to a pretty nice spot.
When you're using vasopressin as a sole agent, are you pushing it beyond the 0.04? We have one trial saying that's okay, and we have a bunch of other trials saying if you have that in combination with the other agents like norepi, badness ensues in terms of gut ischemia and other things. Are you ever pushing that beyond 0.04?
Yes, I am. Do I love it? No. But when I'm at a very bad spot, I will run it as high as 0.08 units per minute. I don't like to do that for extended periods of time. It tends to be kind of a short thing to temporize me through. And, let's be clear, I can cannulate a patient and put a patient on ECMO. So if I'm going to bad places and I'm starting to use a lot of inotropes, a lot of vasopressor, and the etiology is something reversible, something that I can treat with mechanical circulatory support, they're going on pump. Because the goal is less inotropes, less vasopressors, less increase in myocardial oxygen demand. But yes, if you need to temporize yourself, I will do a little bit of that. Just be aware, digital ischemia, gut ischemia, all of those things can be real when you have high dose vasopressor plus, vasopressin plus epi or norepi.
What conditions have we missed that we should discuss, Trina?
So I think it's just really important for the listeners to realize that cardiogenic shock is not, one cardiogenic shock patient is not equal to the other. It's a very heterogeneous disease. A patient that comes in cardiogenic shock due to HOCM and an obstructive physiology like that, they might be someone who actually needs a straight up vasopressor, some increased preload. You don't want to increase their contractility versus the patient that has infectious endocarditis and has severe aortic regurgitation. You might want to have that patient with a faster heart rate. So it's just really important. Look at the physiology in front of you. And like everything in medicine, we're trying to get more personalized. But really, this is an area that this is an art. Know your drugs inside and outside. Know the effects that these drugs have at different doses and really fit it to the patient in front of you.
All right. Anything else we missed in any regard?
No, I love it. I'm so excited for the comments. I feel like we've talked about epi so favorably that there's going to have to be someone who's going to tell us how it's not. But one thing I would tell the listeners is look at the alt shock trial, small trial, but look at all the trials that use epi at inotropic dosing before you comment back to us. And I really want to hear your comments then.
All right. I love it. Let's start the controversy going. Trina, I can't thank you enough for this another fantastic episode of CV-EMCrit, and we will be talking to you soon.
Can't wait. Nice to be here again.
All right, folks, there you go. Second episode on inotropes. Is there more? Yeah, there probably is more. I have in the can an interview I did with John Myberg on inotropes that is very controversial to the viewpoints that Trina and I put up. If that's something that would interest you, put something in the comments. Maybe I'll edit and air that as well. I think a very different take on inotropes than I've been exposed to. I think it would be interesting to hear that one. And I think we hit everything, but if there's still questions after this second episode, by all means, put those in the comments and I'll address them, either on a members Q&A or in some other forum. Scott Weingart for the EMCrit podcast saying bye-bye.